All right, anesthesia. Well, a lot of people are worried about anesthesia, going to sleep and waking up. Especially in men, they seem to have this worry about giving up the steering wheel or the remote control. In other words, I'm the boss, I'm in charge, I'm the captain of the ship, I'm afraid about going to sleep. You can't have the remote control, I'm in charge, I'm driving. And so anesthesia has some risks, and people who are heavy often are worried about that. And so I want to talk about anesthesia, particularly about the developments in anesthesia which make it much, much safer. And it'll take a few minutes to go through this, but I think it's really interesting and exciting and positive. Going to sleep and waking up is pretty simple to understand. If you are awake and you're having surgery, it wouldn't be very pleasant. Imagine somebody is putting a new hip joint in. I mean, where they have to do, they make a cut, and then they find a bone at the top of your hip, and they saw it off, and then they take a big steel spike, and they hammer it down into the center of the bone, and so put me to sleep for that, okay? So you want to be asleep, but going to sleep has its own risks. Right now, as you're awake, your body takes care of so many things for us that we don't have to think about. That's the autonomic nervous system, the nervous system that we don't have to think about. So imagine right now we breathe. Not too fast, not too slow. Just the right amount. Our heart beats and delivers just the right amount of blood and oxygen. And if we need a deep breath, we take it. If we need a yawn, fire away and have a yawn. If Dr. Rutledge is getting kind of boring, you know, he can just drop.
Jet lag.
Jet lag. It's okay. So I think it's really interesting to point out how wonderful and miraculous this kind of breathing system is for us. And if we want to put you to sleep, we can do that, but we have to remember we're going to probably take away the normal reflex that drives the breathing system. Now we can give you some sedatives. That's where you don't actually fall completely asleep. You're kind of sleepy. But again, if you're going to have major surgery, we need to get you so deep under the anesthesia so that your breathing system is also stopped. We don't want to stop it, but that's part of the deal. When we give you enough anesthesia so that you don't feel us working, and you can't wake up, you don't wake up from that while we're doing our surgery, your breathing system is also put to sleep. Okay, so that means that we have to take over. And the way we do that is you get medicine, you go to sleep, and we put a breathing tube in the trachea, and then we breathe with one of those little bags you see on TV. We breathe in oxygen for you, and we take over. So before you're breathing, after you get your medicine, we put the breathing tube in, you're breathing. Okay, sounds good. Now we can put you to sleep using different medicines. The most commonly used kind of medicine is a gas that you breathe in. The gas anesthetics are, most of them, very cheap. You get them by the tube full. You get thousands of doses in one tank. And they work great. But, like anything, they have some side effects. They have two side effects. One that's very annoying that you had, and one that's dangerous. One side effect is if you breathe the gas for anesthesia, 1 person out of 3 will wake up with severe nausea and vomiting. Just that retching and dry heaves, and it's horrible to go through. Not that dangerous, but it's a terrible experience to those people who live through it. The other more dangerous effect is that the gas anesthetics are lipids. They are fat soluble, not water soluble. So they can dissolve in your fat, and when you wake up after the anesthetic, you can be surprised because some of the anesthetic has dissolved in the fat. It can sneak back into the bloodstream and sedate the patient unexpectedly. And if it sedates them enough, they might stop breathing. And so you might have somebody where you had surgery, had gas, woke them up, took them to the recovery room. They think they're all right. Everybody relaxes and steps away from the bed, and then some of the medicine sneaks back into the bloodstream, and they stop breathing, have an irregular heartbeat, and maybe die. So there's the danger of using gas anesthetics. It's not a great danger, but it's a serious danger. And we've seen it in a couple of patients who've had gas anesthetics, so we don't use gas anesthetics. The anesthetics that we use are anesthetics that, number one, don't cause nausea, but they cure nausea. They're anti-nausea. And number two, they're very fast on and very fast off, and they don't dissolve in the fat. So that's good. Now another new development for the anesthetic technique we use is something called opioid-sparing anesthesia. Now what we're saying there is when you wake up or during the surgery or after the surgery, you could have some pain because somebody's replaced your hip. And the normal, usual treatment for that is narcotic pain medicine. Right? You give morphine or Demerol or something like that. But again, like the gas anesthetics, the narcotics have their own side effects. Narcotics side effects are like the gas. They can depress your breathing and can cause nausea. So a lot of researchers have worked on a method to use that we can decrease your pain and protect you from nausea. We want to use opioid-sparing, opioid or narcotic-sparing anesthesia. What we found is two sets of drugs that can help decrease the need for narcotics. One is an old drug that's been around forever called ketamine, and ketamine is a anesthetic that we've used in low dose now and can really decrease the need for narcotics. And the other is a new drug called dexmedetomidine or Precedex, which also can decrease the pain and decrease the need for narcotics, so that then your breathing is better, you're safer, but you still have pain relief. And so those are our new techniques that we've been using for a year now, which are much safer than the older techniques we used.